Hello, everyone. Welcome to our Cat Project Echo. It's good to see everybody here. So as you know, we're just starting out like a new group, although some of the people in this group have been around since last summer, but most of us are coming in new at this time. My name is Joanne Jung. I'm actually a general pediatrician. I'm not a specialist. But I help to organize some of the CME activities here at CAP. And also want to introduce Dr. Eileen Wong, who's a child and adolescent psychiatrist who also helps to organize our events here. And we have Mei Lum, who's our project manager for CAP and helps to keep us organized. And I'll be introducing our speakers in just a moment. But as folks are coming in, I'd like to invite you, since we don't have time necessarily to go around and introduce all of us in person, please put into the chat, just put in your name, what county you're part of, and maybe the name of the organization that you work for, at least to start. So just go ahead and type that into the chat. And May, if you wouldn't mind going ahead and putting up our share screen. Wonderful. So great. So let's go ahead and move on to the next screen, please. So please do type into the chat your name, your organization, what county you're in. And I'm actually going to be fancy and launch a little poll here. How do you feel about screening tools? So, so you can just like take a moment to answer the poll. And let's see how people feel. And one other thing I'd like to ask is if you could go ahead and turn on your camera. I'm assuming that we are all eating because it is the lunch hour, and I think that's okay. And so please do turn on your camera if you're able to do that, just so that we can, especially in our first meeting, so we can get to see each other. We're coming in from all across California, from way up north near the Oregon border, down through the Bay Area and through the Central Valley. So we can't physically be in the same room, but I'm hoping that as we get to know each other over the next few months, this could actually be something of a community here. And so, so turning on the camera really does help with that. And so I don't know if I'll go ahead and end the poll here, and I'll share the results. So I don't know if people can see up here. We've got a lot of fans of measurement-based care and a few people who want to find out more. So, or maybe not find out more. But that is our topic of the day. And hopefully by the end of it, you'll be convinced that this is actually worth trying out and learning more about. So with that, let's go ahead and go on to the next slide.
And I don't know if everybody could see the results, but it looks like 47% of folks said thumbs up, and then 27% said such a strong tool. And then we've got about 25% saying, what's that again? Or snooze fest.
Petra. All right. So with that, you will be getting a bunch of emails if you haven't already, if you signed up. And I wanted to give you a little orientation as to what these all are. When you clicked on the register here link, hopefully you've done all like the registration emails. That's so we know who you are, can give you CME credit later on. There's an MOC Part 2 pretest. And then this will set you up to get our CME surveys every month, which we need to do in order to stay accredited as a CME provider. So please be on the lookout for those surveys every month as they come. For all those who registered by about 11 a.m. today, you'll be getting an email that invites you to an optional ABP MOC Part 4 activity. And what that is like a chance to do some quality improvement around adolescent depression screening at well child visits, plus your response to them. So just getting some baseline measures. Are you screening? How many are you screening? Do you have a treatment plan? What's in your treatment plan? And this is just our chance to review our own charts every 3 months. Like we'll be checking the last 10 well child visits we've done and doing a quick chart review and answering a couple of questions on each one. And the survey will automatically give you your metrics, what percentage you're screening, what percentage of those diagnosed with depression actually have some kind of treatment plan. And then please do download these so that you can follow these over time. And those who complete all 3 rounds of data collection will be eligible for American Board of Pediatrics MOC Part 4 credit. And so it's optional. You can participate in this echo without doing this, but it's an opportunity. And I see a few people on here who have already started, so you don't need to register again, okay? Just continue on the track that you're already on. But this is a chance for those who are new to be able to join in on this if it sounds interesting to you. And somewhere along the way, I think we added into our registration surveys this time around, there's a little burnout survey, and I think that'll also give you your own personal burnout measures, but it's a little research that we're doing into does participation in an echo like this actually help with some of our own burnout? And so if you have a few extra minutes, welcome you to fill that out as well. So next slide, please. Okay, so how do you, speaking of like MOC type stuff, please stay on to the very end because we flash up a QR code at the end and give you a link. You can either click on the link or scan the QR code in order to check in for this activity, and that's how you get credit, CME credit for attending these sessions. And for those of you who aren't familiar with Project Echo, the heart of this is discussing our cases. Okay, we have a little bit of didactic, but then it's followed by case discussion, and this is really where we learn. So I'd like to invite you to please share your cases with us, and there will be an email again coming out with a chance for you to sign up for a case. And if this is a little bit of extra incentive, those who share cases don't need to take that MOC post-test to get Part 2 credit. Okay, so if you get up here and share, you get that credit even without like passing that post test. So the cases should ideally match our topic, and these are the upcoming topics you see here. So next month is on sleep. So if you've got a patient with sleep problems that aren't responding to the usual, like please do let me know, and maybe we can get everybody's feedback on the case here. I want to share a quote that I heard from an attending when I was an intern, and it was, good judgment is a product of experience, which is the product of bad judgment. Okay. And a quote from one of our early ECHO participants, which is, we all feel like interns again in this mental health space. So we don't need to have a nice pretty bow or all the answers or think that we are teaching from this case. By no means. These are the cases that are keeping us awake at night or thinking and thinking and thinking after the day is done and wondering, what should I do? Can I talk this over? And so this is a chance to talk this over with our peers as well as with our subject matter experts, and getting hopefully some helpful input and group learning along the way. So no such thing as a dumb question. Please do bring your cases and your questions because that's how we learn together. All right, so next slide, please. So with that, we will turn over to didactic. I wanted to introduce our speakers today. Dr. Anna Swan is a clinical psychologist who is, I guess, moving on from UCSF, it has been a long-standing faculty here, clinical faculty with expertise in treating anxiety and ADHD, among other things. And Dr. Petra Steinbuchel is a child and adolescent psychiatrist and actually the director for the Child and Adolescent Psychiatry Portal. So she leads us here at CAP. And they will be speaking today on assessment and screening tools. We will be recording this didactic presentation, just so you know. And this didactic will be posted online, but our pictures will not be part of it. So with that, I'll turn things over to Dr. Steinbuchel and Swan.
Hi, everyone. Nice to see so many familiar faces. If we can move to the next slide, please. So these are our disclosures. We do receive federal funding from HRSA and have been receiving also Department of Healthcare Services from the state for Prop 56 behavioral health integration funding. And then I have received stock options for being an advisor to Little Otter Health, which is a age 0 to 12 telehealth corporation that provides telehealth and care coordination services for that age group. Next slide. So today we want to talk about what are the benefits of measurement-based care, as well as some potential barriers, and have you be able to describe at least 2 screening tools that you can use to screen and assess, and also how to think about applying measurement-based care principles to your treatment plan. Next slide. So this is from pediatrics. This is about preparing future pediatricians to meet the behavioral health needs of children. And this is a really great article, but I'd like to emphasize one of these columns here that really, I think, captures the spirit of what we at CAP are trying to do and want to convey in terms of guiding principles. So the idea that we include parent and youth and young adult voice and choice throughout the entirety of, in this case, pediatric residency training, and also in our daily practice. And that we want to look at how can we get help from family and peer support groups to develop scripts and having those language pearls that we can use when we're talking with families, because sometimes it's hard to go into the realm of mental health, or it can feel hard at the very beginning. And then you start to develop some catchphrases that can be really helpful. We also want to expand trainees' understanding of development to include thinking about well-being. We think about, health and mental health concerns on a continuum of severity, and, not everything needs the highest level of intervention, but how can we promote health? And I was recently part of a training where I really appreciated the presenter talking about, life and health is what happens in between physicians' visits. And so we as providers need to kind of step out of that need to manage things, or think that we're really truly addressing all of someone's health or mental health within that visit, but rather how can we set them up for success in that life outside. And then here, the last one is really important, letting go of what is typical or normal, thinking about, shoulds, and a more, older version of thinking about pathology or lack of pathology. But again, rather, we're all on a continuum, and that there's really no way to know how someone is going to respond to a stressful life event or acute or chronic illness. So we need to think about being curious before we think about making a quick judgment or making a quick diagnosis. Next. Part of this really means talking about or embedding a strengths-based approach. So shifting the narrative, and this is from trauma-informed care principles, shifting it from what's wrong with you, which, we need to come up with diagnoses and identify that pathology, if you will, but rather we want to shift our thinking around it to what has happened to you, and then also what is right with you, because starting the conversation with, what is going well for you, what do you feel like you're good at, what would a friend say that they like about you, can be profoundly motivating for young people to engage. And they may be feeling very ashamed or worried that you're going to judge them or think about it from a very pathology-driven place. And so if you can start with those strengths, then that helps the person to be seen and known and more motivated to engage. Next. So in terms of measurement-based care in the pediatric setting, these are some core elements that are thought to be really useful about it. This is from Barry Sarvet, who is one of the founders of the MCPAP program and really leads efforts for CAP-style programs in different states across the United States. So these 4 things, basically that measurement-based care offers the potential to improve the type of care that is offered within the primary care setting. It allows you to be more clinically specific and to use algorithms that help improve not only your accuracy of diagnostics and assessment, but also as a way of communicating with other team members. Because if you say the PHQ-9 was 19, that's very different than a PHQ-9 of 4. And you're starting, with a shared understanding of what that means. This is more at the systems level, this third point, that this measurement-based care can generate data that allows primary care practices to address population health goals and improve performance. And this may be true as especially FQHC settings are moving more and more towards HEDIS metrics and being accountable with those. And it will also help in terms of insurance contracting and creating accountability and ways of measuring progress. And then last, and this is really important, that these types of measures should be used to complement, but are never ever a replacement for clinical judgment. And we're going to try and emphasize that throughout this brief talk, that it's a both and of being able to use the screeners, but also to look at the big picture of what is actually happening. Next. And I think this is you. Are you able to connect?
So just as a heads up, I'm getting some messaging that my internet connection is not stable. So if I hop off, I'll hop right back on. So this slide is about measurement-based treatment to target. And this means that measurement-based care can both guide our initial treatment planning, but also help us modify treatment planning along the way to be able to meet the family goals. And so initially with our treatment plan, measurement-based care helps us to work together as the whole care team to develop goals that are observable and have measurable outcomes. And so this might be something like if you're treating depression, looking for a goal of a PHQ-9 score less than 4, but it could also include things like a functional goal. So if you have a teen who's having a hard time going to school because of their mood, a functional goal might be attending 4 out of 5 school days. And then being able to measure these outcomes routinely and also considering flexible treatment options that really emphasize this family being able to access care sooner rather than later. And then treatment to target is about modifying treatment plans along the way until we're able to meet those goals. And this is helped along by the fact that we're routinely measuring these clinical outcomes using evidence-based tools. So for example, in the primary care setting, this might be sort of starting with using some standardized rating scales when you're initiating a treatment plan, and then re-administering those scales at every point of contact for the first 3 months, and then kind of fading that out depending on how things are going. I'm thinking about some teens that I've been working with lately who are struggling with depression. And so at the start of our sessions, I'll give a PHQ-9, and we sort of use that as a clinical tool to be able to talk about how things are going. And in these cases that I'm thinking about, treatment was not really helping us meet our goals. These teens were continuing to struggle with depression. So the fact that we were routinely measuring outcomes really helped to kind of build some momentum around thinking about how to change the treatment plan. It helped the family to consider things like maybe a medication consultation when they had been hesitant before, thinking about other ways to change up our therapy to better provide support. And of course, it's always so rewarding when you see the scores start to go down and these teens be able to get back to their life without their symptoms getting in the way. Next slide, please. So then the question becomes, what are the measures that you can use to complement your own clinical judgment when you're thinking about diagnosing common conditions? And so we're going to start with the PEDS symptom checklist. I'm curious, with a show of virtual hands, does anybody already use this in their practice or is familiar with it? And I actually can't see everybody's virtual hands, but so this is I'm seeing some thumbs up. Awesome. So this is a great measure because it's normed for ages 4 to 17. So it covers a really broad age range. There are both caregiver and youth report forms, and we have them available on the CAP portal resource page in English, Spanish, and Chinese. And this is a great screener that highlights concern in 4 areas that are pretty common to come up in primary care. So one is concern for inattention, hyperactivity, impulsivity, things you might see with ADHD. The second is concern for anxiety. The third, concern for depression and low mood. And the fourth, concern for externalizing problems like disruptive behavior, things you might see with oppositional defiance or conduct problems. And then there's kind of an overall score noting concern for any diagnosis. And for such a short 17-item measure, it actually holds up quite well compared to some of the longer rating scales like the child behavior checklist for identifying these concerns. So it's a really kind of nice place to start and then to be able to follow up with some additional measures to get some more information about the concerns that were highlighted. Next slide, please. So on this slide, we have some of those secondary screening tools and rating scales that were really designed to focus on a specific set of symptoms. And I'll go into each of these briefly, but I also want to highlight that we have echoes on each of these areas of concerns, as well as some webinars that go into more depth about assessment and treatment options than we're able to do today. So the first area I want to talk about is assessing depression. Again, I'm curious, with a show of virtual hands or thumbs up, who's familiar with the PHQ-9 and is already using this in their practice? I imagine, yeah, seeing some hands, yes. So this is a wonderful measure to assess depressive symptoms, normed for ages 12 up to 17. And then the mood and feelings questionnaire is also really nice if you're concerned about mood in a younger kid, because it goes as low as 6 all the way up to 19. Again, curious, who is familiar with the GAD-7? Like this one is being used, some hands raised, yeah. So this is normed starting at age 12, and it asks a lot of questions about worry, the kinds of things that you might see with generalized anxiety disorders. That's a really nice initial screener. And then I want to highlight these 2 other measures, the SCARED and the ARCADS. This has a broader age range. So if you're wondering about anxiety symptoms in children as young as 8 all the way up to 18, these are good tools to use. And similarly, there's the youth report form, but also the caregiver report form. So specifically, if you're wondering about these concerns in a younger kid who might not be as aware, it's nice to be able to have the caregiver report forms. And for a teen where the parents might not be as aware, it's nice to be able to get their ratings as well. So the SCARED provides kind of an overall anxiety rating score, but then it also has subscales that highlight concern in specific areas like separation anxiety or social anxiety or other anxiety disorders. And so this can be really helpful for kind of fleshing out what are the ways that anxiety is coming up for this child or teen. And then the ARCADS is something that we use a lot in my clinic because it measures both anxiety and depressive symptoms. And so we administer this, at the start of treatment, but usually every 6 to 8 weeks to help monitor progress. And similarly, it has kind of an overall score to indicate internalizing concerns, but also has subscales that really pull out depression versus other anxiety disorders. For screening for ADHD, I am sure that most of you are familiar with the Vanderbilt. I was in a primary care setting back in the day on internship, and we just had boxes of Vanderbilts everywhere. It was such a helpful tool for screening for ADHD. And it's designed for children 6 to 12. They're the caregiver report forms, but also teacher report forms, so you can see how these symptoms are manifesting across settings. It is sometimes used for assessing ADHD symptoms in teens older than 12. But another tool that you could use instead is the SNAP-4, which is normed for ages 6 to 18. In terms of assessing for suicidality, I think more and more people are using the ASK, which is the Ask Suicide Screening Questions. It involves the clinician asking 4 brief questions about suicidality that takes about 20 seconds to do, so it's really fast. And then there's a whole toolkit that's available online that provides some really nice guidance on, well, what do you do next? And so based on the responses that you get, you might not need any additional follow-up, or it might recommend doing a brief suicide safety assessment that takes about 10 minutes, or recommending a full mental health evaluation or other care. And then the Columbia Suicide Severity Rating Scale is also a really nice measure of suicidality. In terms of substance use, the CRAFT is a quick 6-question measure that can either be self-report or you can ask in a clinical interview. That's a well-validated substance use screening tool for adolescents 12 to 21 and is recommended by the American Academy of Pediatrics Bright Future Guidelines for care screenings and well visits. And then lastly, we've included 2 screeners that can help assess the impact of trauma, the Pediatric Traumatic Stress Screening Tool and the Child PTSD Symptom Scale. We wanted to note that a lot of the trauma symptoms that are picked up on these screeners are also captured in the anxiety and depression rating scales. So rather than using this as a routine screener, you might use this as a secondary screener in addition to a clinical interview if you're already feeling like you're grounded in trauma-informed care. When you're using these screening tools, you don't need to ask the family or teen to share, details about the trauma that they've experienced, because that could be triggering in the primary care setting. And we also wanted to note that there's going to be a whole webinar on trauma assessment and primary care in February. And there was an echo back in December as well that's able to go into this in much more depth. Next slide. And so overall, these tools can be so helpful because they help us identify common conditions that might otherwise go overlooked. And particularly a lot of these conditions, depending on what's coming up, it's going to lead to a different treatment response, and there are effective treatments that are available. So it's really nice to be able to use these screening tools and rating scales as a complement to clinical interview. In my practice, a lot of times I might start with a rating scale and then use that as a jumping off point to ask follow-up questions to get more clarity. And it can be a really helpful clinical tool to use as well throughout the treatment process to assess, how things are going and if we need to make a change. Next slide.
So just to dovetail on what Anna was saying, I think that, always using these as kind of a starting off point. I sometimes will take a look at the screens when they're completed. And if I have a question, for example, in the PHQ-9, it asks about sleep. It says, do you sleep too much, too little? It doesn't really clarify. So some of the ones, if I have a question about it, I'll ask, some follow-up around that. Similarly with the PHQ-9 and asking about suicidality and self-harm, it doesn't really differentiate those two. So again, you want to be able to qualify the quantitative information that you're getting. And so these guidelines over here to the right, they fit nicely into tables, and this can be a real, a helpful guideline in thinking about how severe is this, what needs to happen. I will say under the mild with watchful waiting, there can be some amount of psychoeducation that happens, and also thinking about positive event scheduling, sharing about some of the stress busters that are part of, ACEs aware training. And then when do you think about medication? That said, there may be exceptions to this. So it doesn't have to be that you have a score of, 20 and then absolutely start a medication, or, the opposite of that. But these are just helpful to consider. And again, mixed with clinical judgment. Next slide. So another factor in implementation that is important to consider is that, what is the actual usability? These are really nice and helpful to have, but I think we've all experienced, systems or moments where you don't have access to the paper form, or the patient couldn't sign up for my chart to complete the PHQ in advance, or things like this. And so what is the overall system usability for you as the clinician? And what is the usability for patients and families to access these? And then how are you monitoring progress? Are there embedded supports that do this easily, where you can track these things over time within your EHR? Or do you have your own system for tracking this? And then how often do you share it with the patient? Studies have shown that being able to talk about this and use this as a conversation and feedback tool for patients have found that really helpful, because they can see their scores changing. They can see how you're thinking about treatment considerations based on the scores in part, and also based on, what they're saying that they want to get out of treatment. It's important to think about unintended disparities, because there have been a couple of studies that have looked at the sign up rate for things like my chart or whatever portal system is being utilized, and found that lower income, and with that often communities of color have a lower frequency of signing up for portal access. And some of that had to do with clinician differences, and also process differences. And so being able to make those processes uniform, and for people to have access to completing these screeners as much as possible. This image here was based on a study that was done at Mass General Brigham, which has had an EHR for a very long time and has done screening across the board, really across all races and ethnicities. However, if you look at the timestamp on this, so basically screening across the board in the top graph was fairly consistent for most races and ethnicities before COVID. And this was when most of the screening was actually done on a tablet within the clinic. And then when it switched to everything being remote and telehealth, and everything required entering it into a portal in advance of the appointment, that's where you really see these ethnic and racial disparities emerge amongst different groups. So the top two groups are Caucasian and Asian, and then the yellow is Black or African American, and then the lowest was Hispanic or Latino populations. And next slide. Another part of this is just, looking at who is this person in front of you, who is the family in front of you, how are you thinking about your mental status exam as part of your overall evaluation. And, we rely so heavily on language and words. And so it's important to think about what are the nonverbal cues that you're seeing. How is someone dressed? What's their body language? What does it feel like to be with them? Somebody can be incredibly articulate, but if it doesn't match with what you're seeing and feeling, then that's a clue that there's something that's not quite accurate here. And that can include over-reporting or under-reporting on these rating scales. Next slide. Anna,
And so here we've included some language pearls that you can feel free to steal and make your own as you are kind of getting comfortable talking about mental health concerns in primary care. And really at its core, what you're wanting the family to come away from this meeting understanding is that you see them, you hear the concerns, and you care about them. So I always like to start with normalizing. So as particularly if it's a family where they might be hesitant for whatever reason to share, and I might say things like, lots of children, teens, or families are experiencing fill in the blank. It's really common to have trouble sleeping. It's really common to feel more nervous around transition. Does that sound like you? And I find that, the more that I kind of normalize this, the more families are able to share. In terms of trust, particularly with teens, I think it's incredibly important to be talking about confidentiality and the limits of confidentiality, and then to be able to say things like,
I think we might have lost Anna with the Wi-Fi. We're just recognizing that we're low on time and want to have adequate time for the case discussion, but we will share the pearls here. Next slide. So this is really just in summary, thinking about what are the scores, what are your clinical impressions, and then how is the child actually doing at home, socially, in the community? Are they meeting their different developmental milestones? And then adding that together with what are their strengths? What do they want? What does the family want? Where do they live? What's actually going to be practical and possible, both based on their insurance and also what they can actually access, whether that's telehealth or local resources or otherwise. And then from there, developing a treatment plan together. And with that, we'll end here.
Thank you so much, Petra and Anna, for sharing this great presentation. We will share a tip sheet that will go out for everyone, so you can review this in greater detail later.